for us this morning to share the information you have. So thank you so much.
You bet, Dave. Thanks. It's nice to be here again. Actually, I did a presentation on the cardio-renal syndrome, the heart-kidney connection, and how one can't get by without the other about 2 years ago, I think it was, and it was very gratifying group to present to. I'm very engaged, and I've been looking forward to talking to you groups again. I recognize some of the faces, a lot of new faces too, but it's great to be back, and thank you for letting us share our current initiative with you. So the last time I was here, I was talking about primarily, I was coming to you as a nephrologist from the community discussing the cardiorenal syndrome, and now I'm coming to you as a member of the Mount Baker Foundation. And I'm going to start up with the first slide. The Mount Baker Foundation started about 3 years ago after the sale of the not-for-profit Mount Baker Kidney Center to DaVita, and we spent a considerable time looking at what we would devote our energies to, and the three focus areas included early childhood education, upstream causes of disease, and importantly, continuing to have a focus on patients with kidney disease, specifically dialysis patients and transplant patients as well, and how we can make their lives better and contribute to their care. We conducted a survey of the dialysis patients about a year ago now, and one of the things that we received in the feedback from them is that they felt that most people they know didn't know much about kidney disease, and in fact didn't know much about kidneys. And so that, and with input from the staff of the Kidney Center, who also said, we just see this repeatedly, poor people showing up saying, God, I had no idea I was even at risk for this, or could possibly have kidney disease. We felt that an initiative to educate our community and increase the awareness about kidney disease was important. As the more time we thought about it, the work group that got put together to work on this decided, rather than talking about kidney disease, let's talk about healthy kidneys, healthy me, because it's a much more positive message. And if we think about keeping our kidneys healthy, we'll avoid the other problems. And chronic kidney disease has been called the silent epidemic. And it's called the silent epidemic for a couple of reasons. The first off is silent because most of us are unaware how many people are out there with kidney disease or kidney failure. And secondly, those of us that have kidney disease are oftentimes unaware of it because the redundancy of the function of the kidneys is such that you can lose 70% of your kidney function and not know that you're at risk for at the tipping point for going into kidney failure. And finally, it's an epidemic simply by virtue of its proportions. So what is the risk of kidney disease? Well, so it turns out 1 in 3 of us are at risk for having kidney disease or have a risk factor for it. So if you look at the collection of people on our Zoom today and look at the person to your left and the person to your right and yourself, there's a significant likelihood that one of you has a risk factor for kidney disease. And the question is, are you the one? Some more numbers are, since 33% of us are at risk, when you look at the population of the United States, 37 million people are estimated by the CDC to actually have kidney disease. Only 1 in 10 actually know that they have it. 1 in 2 people with very low kidney function who are not yet on dialysis, but very close to it, don't know they have kidney disease. Our experience at the Mount Baker Kidney Center in Bellingham was that we oftentimes saw 40 to 50% of the patients coming for dialysis for their first treatment never having seen a kidney specialist, which is a really significant problem for them because they've not had pre-dialysis education to tell them what to expect, consequently have fear and anxiety about it. They haven't learned about what kind of things they can do diet. They haven't learned about what kind of things they can do for themselves to keep themselves healthier. And very importantly, if they're coming to hemodialysis, they don't have a functioning access to the circulation, which can safely conduct dialysis. Instead, they oftentimes have a catheter that's tunneled into the skin and into the jugular vein, which carries about a 25% mortality in the first year. So something you really don't want to have happen. On a bigger picture, the Veterans Administration conducted a study and was found that 60% of the veterans coming to dialysis have also never seen a nephrologist. So it's a big problem that people are unaware that they have kidney disease, even when it's quite severe. Looking at the global picture of this, if we go up to the 10,000-foot view, 780 million of the population worldwide are affected with kidney disease, and millions die each year because they do not have access to affordable care for this. More than 2 million people worldwide are treated with dialysis or have a transplant, but this only represents 10% of the people who actually need it. And as you might imagine, those 2 million people that are getting treated are concentrated in 5 big countries with robust healthcare systems like the United States, Japan, Germany, Brazil, and Italy. So this is the first stop I have to ask, are there any questions regarding the statistics or the risks? We're going to talk about the specific risk factors in a minute, but anything about the risk issues about kidney disease?
Dr. Lombard, how does kidney disease present itself? I mean, if you didn't know you have it, I mean, is there some signs that come along that kind of give you a clue that there's something wrong?
If you don't have certain specific kidney disease, which only account for about 15% of them, David, oftentimes you don't. I mean, the most common thing is people lose kidney function is fatigue, weakness, loss of appetite. They might start developing ankle swelling from fluid retention, just as you would see with congestive heart failure, though. Oftentimes, the only change in their urine flow that they notice is that they pee more often at night than they did before. But a lot of guys do that anyhow, as we all know, those guys out there. But the reason is they can't concentrate the urine because of the kidney failure. So oftentimes, really, the symptoms are very vague. And so the best way to approach it is see if you have one of the risk factors and then make sure you get checked up regularly for it. And that's the basic message we're going to go over today. Any other questions? Okay. Okay, where are kidneys and what do they do? And where are they and what do they look like? What do they do for us? Well, what do they do for us in the next slide? Where are they? The kidneys are actually located on the lower margin of our ribs, on the back, and the very back of the abdominal cavity. So they're in a very well protected space. And I think they evolved that way simply because they get so much blood flow that if they were anywhere else, it would be very easy for them to get knocked around by trauma and have the blood vessels disrupted or the ureters disrupted. They're about the size of a fist, and the kidney on the picture on the right is actually a kidney which has been removed from someone for transplantation. And you can see, sure enough, it's fist size. And here's the ureter, which is this anatomical unit that goes down to the bladder. Talking about kidney donation and taking out a kidney, most people that have normal kidney function can donate a kidney and never miss it. Their kidney function will be almost entirely normal the rest of their life, and they almost certainly will have no medical problems. It's kind of the part of the redundancy built into the system. So what do kidneys do? Well, they do a number of things, and we'll talk about these 6 functions. The first is they regulate blood pressure. They secrete hormones which raise the blood pressure, and they also secrete a hormone that can lower the blood pressure, but that's a minor role compared to high blood pressure. They activate the vitamin D that we take in either from diet or is created in our skin from sunlight. And that form of vitamin D is critical to absorbing calcium from the intestinal tract. So they really play an important role in having healthy bones. They secrete a hormone called erythropoietin, or EPO, some people may know it as. And this hormone directs the bone marrow cells to start making more red cells. So they actually control the level of our red blood cell count. In the old days, before EPO was available as a drug to administer to people, all patients on dialysis had horribly low red blood counts, which significantly contributed to the morbidity associated with that disease and also to the subsequent development of heart failure. In a typical day, our kidneys filter about 120 to 150 quarts of liquid from our blood. In doing so, obviously we don't urinate that much, so it's got a lot of work to do to reabsorb that fluid. And the way that works is they reabsorb the water that we need, they reabsorb sodium, they reabsorb calcium, they try to get rid of potassium and phosphorus, they reabsorb any amino acids or glucose that's filtered. They do not reabsorb the waste products, so that stays in the filtrate, and then they balance the amount of water by a very complex mechanism with including the brain, and maintain that our body's balanced fluid. Our body's fluid balance. They really maintain the internal environment of the body. Regarding fluid, and you can imagine, think about a day when you might drink an extra quart of water. It doesn't take long before you know that it's time to get rid of it, and you have to pee more. That's all the kidney quickly recognizing that I need to tightly balance what this fluid balance is. Any questions about anatomy or function of the kidneys? Okay, if not, anybody there? Again, if you have a question, it's okay with me if you just unmute and ask it. Okay. So what are the risk factors for kidney disease? Diabetes is probably the paramount one. Diabetes accounts for about 50% of the patients who start dialysis every year. Hypertension by itself also contributes to another significant percentage, and the two of these account for 3/4 of the patients starting dialysis. When you combine the two, it's a particularly bad combination, which just tends to hasten the development of kidney injury. A positive family history, anyone who's had a family member who has been on dialysis, who required a kidney transplant, or developed kidney failure in the remote past, increases our risks of developing kidney disease. Ethnicity plays a significant role also. African Americans, Hispanics, and American Indians all have a very significant increased risk of developing kidney disease and kidney failure. Age over 60 is a significant risk factor. All of us in this age group, if you were to check the kidney function of everyone on this meeting, you'd find that about 30% of us have some decrease in our kidney function compared to baseline or normal. And finally, heart disease plays a very significant role also. About 35% of people with heart failure have chronic kidney disease, and it both aggravates the heart disease and it makes it more difficult. Certainly makes the heart failure more difficult to control. So we mentioned before, about 1 in 3 adults with diabetes have chronic kidney disease, and 1 in 5 of adults with high blood pressure are also likely to have chronic kidney disease. Any questions about the risk factors?
Yes, Dr. Lombard, I had a question regarding diabetes and the hypertension. So if you're able to control it, does that reduce the risk factor slightly, or?
Absolutely, Brad. That's one of the bottom line messages for us today, is to make sure that you control your blood pressure and control diabetes, and you can prevent the development of kidney failure for years. Very important to do. Anyone else? Okay. So how do you find out if you're the one at risk? Well, there's a great little website, minuteforyourkidneys.org. This has been put up by the National Kidney Foundation. If you log on, there's a quick, truly 1 minute, 5-question interactive site that you put in your answers of whether or not you have a diagnosis or a history of diabetes or high blood pressure or a family history or what your ethnicity is. And they also ask for your weight and height. And if you have a risk factor, when you push enter, it says you have a risk factor. We can send you, they say, we can send you a urine test to your house that you can do at home. And with it does require a smartphone, but with that, it'll tell you if you have an elevated albumin level in your urine, which signifies that you do have some kidney injury. And that actually looks like this. I took the test and said I had diabetes and high blood pressure, and it sent me this kit at home. It has a little urine cup that expands out. It has a dipstick in here. The first thing you actually do is you take a picture of the color board, and the QR code does whatever it does magically to create an interpretation screen. Then you take the dipstick, dip it in the urine, wipe it off here, slide it into here, and then use your phone again, and it will tell you what your albumin to creatinine ratio is in your urine. What I can tell you is when I ordered this urine test, I saved the kit so I would have it just for things like this to show people what it looks like. I have had weekly emails from them, and I've had 2 phone calls from them saying, "Where's your urine test? And have you seen a doctor yet?" And so finally yesterday, when I'm on the email, said, "Have you seen a physician yet about your kidney risk?" I said, "Yes." And they said, "Good work. Stay in touch." and they will continue to make sure that you're getting things taken care of. Going back up here again. So this is quick and easy. When I did this for our Mount Baker Foundation board the other day, and one of the members, while we were having the Zoom, actually went on to her iPad and did the test and said, "This really works." And she said, "By God, I got 2 risk factors. I'm gonna go and see someone about that." Okay, so that's a quick and easy one you can do yourself, and you get the urine test done as well. The next thing is discuss whether or not you have risk factors, or discuss your risk factors with your doctor, just as Brad said, and say, "Hey, I have diabetes and hypertension. What's my risk here of developing kidney disease, and what can I do about it?" And then if not, you say, "It's been a while since I had a urine test. Can you check my urine for protein and other things? And can I get a blood test to see what my kidney function level is?" And then if you go to the mountbakerfoundation.org website, we now, for the month of March, which by the way is National Kidney Month, we're going to have there's a whole education website, and it will not go away. That stuff will remain there, but it also takes you to this link for the minuteforyourkidneys.org, but it also has a number of really good, quick informational things to tell you more about kidney disease. Any questions about how to find out if you're at risk?
I have a question. If you have a blood test, what are the things that that you read to see if there's a kidney problem? What are the initials and things?
Great question, Jane. The creatinine, and from that's creatinine, from the creatinine level, which has a fairly wide range. So the range is 0.8 to 1.2. And that range is because some of creatinine, let me step back, and creatinine is made by the metabolism of our muscles every day. So a guy that is a big muscular weight builder is going to be up around 1.2. And those of us that don't do as much exercise and have smaller muscle masses would be closer to 0.8, 0.9, 1.0. So that's a rough measure of it. They then now include in almost every lab in the country now an estimated GFR, that's small e, capital G, capital F, capital R, which stands for glomerular filtration rate. And that tells you basically what your function is. The normal value for that should be clearly above 60 and ideally above 90. There are other things we look for, but relative to what we're talking today about diagnosing kidney disease, that's the critical one, Jane. Anyone else have a question about that? Okay. So what if you are the one at risk? Well, The ideal thing is that your doctor should monitor you regularly with blood tests and urine tests, looking to see if you're developing albumin in your urine, and to see what your glomerular filtration rate is doing. If your glomerular filtration rate is going down, meaning your kidneys are losing function and the protein excretion is going up, then you may reach a point and say, hey, when is it appropriate for me to see a kidney specialist to get an input on this? It may be if he says, well, I don't know why your kidneys are having a problem here, you probably want to see a nephrologist then anyhow, because you might have one of the more unusual things that requires a little closer investigation. And generally, as your kidney disease, if you are at risk and you do develop problems with your GFR going down and protein going up, at some point the nephrologist will be involved and co-manage with your primary care doctor. What happens if you have kidney disease already, and how do you lower your risk for progressing to kidney failure? Well, the first thing to do is learn from your nephrologist what your disease is and are there specific treatments for that disease. So, for example, there are certain diseases like polycystic kidney disease, which is an inherited disorder where the kidney is replaced by a bunch of cysts. There are some specific medications you can take to reduce the growth of the cysts and reduce the injury to the surrounding tissue. There are certain forms of nephritis which require specific therapy. But he will also say, these are the things you want to do. He or she, the nephrologist, should say, these are the things you're going to want to do to protect your kidneys from getting worse. Key amongst those are the things we alluded to early. If you manage your blood sugar to the A1C hemoglobin that your doctor recommends for you, that will be the best thing to do. And the A1C, how tight you can target that to a value of 6 varies widely depending upon the type of diabetes you have and also the medications that you're taking. If you make it too tight and you control your blood sugars too closely, you end up with having a significant risk of low blood sugar episodes and risk of sudden unconsciousness. Blood pressure control is critical. There's really 2 ranges. For people that do not have a lot of protein in their urine and do not have heart failure, 140, less than 140/90 is appropriate. For people that have heart failure, your cardiologist will tell you what pressure range he wants it to be in. If you have a lot of protein in your urine, then level under 120/75 is more appropriate because that's been shown clearly to reduce the progression of kidney disease. And then managing the kidney disease are some pretty straightforward things. First off is eating healthy, meaning specifically a low salt, low fat diet, exercising regularly and controlling weight. Part of that relates to the fact that chronic kidney disease does carry an increased risk and seems to accelerate vascular disease, and you want to keep those things controlled. If there are specific medications, specifically some of the blood pressure medicines, which are also used for heart failure, like lisinopril and losartan, the so-called ACE inhibitors and ARBs, which have been shown clearly to slow the decline of kidney function over time. There was one case I recall of a young gal who I met when I first came to town back in the early 80s who had kidney failure associated with diabetes at the time of first and only pregnancy. And that was back when this was first known as a way of delaying the onset of kidney failure. And she took those for 35 years and her kidney function decreased, but never got less than 30%. Next point, work with your healthcare team to monitor your kidney health, making sure you get your blood tests and urine tests regularly. You want to avoid exposures to things that can harm your kidneys. There are certain medications like all the anti-inflammatory drugs like ibuprofen or Aleve and that whole group of drugs. There are certain antibiotics, particularly the sulfa drugs, which can, taken in regular doses, can damage the kidneys. And then the acid suppressing drugs like omeprazole, Prilosec, Prevacid. Very few people that take those get a problem from them, but it's actually an allergic injury to the kidney. But the only reason it's a significant risk is because there are so many people taking those drugs. Every year we would see about a half a dozen people who had a slowly developing kidney injury, and it was due to those drugs, which you can actually demonstrate by a kidney biopsy. And you stop the drugs and it gets better. So that's something we just need to always keep in mind. You should not take any supplements if you have kidney failure or kidney disease without talking to your doctor. And then the intravenous dye that we use for CAT scans and heart catheterizations, including stent procedures and TAVRs, can damage kidneys, particularly when it's used in large quantities, like are required for some of the more invasive procedures. If you have normal kidney function, it is generally not an issue. If you're starting off with good kidney function, it's not a problem. But if you're starting off with reduced kidney function, this can have a bad impact. And again, you know what? All the cardiologists in the community are aware of that, and they all check your kidney function before you get dye. The next thing is I doubt that many people in this group still smoke, but smoking, interestingly, accelerates the development of kidney failure in those with chronic kidney disease. Any questions about how you can lower your risk for progressive kidney failure? Okay. So what happens when kidneys fail? Well, there's basically three groups of therapy. A transplant is the ideal thing. People do best when the kidney is received from a living donor because the kidney is very fresh and is just taken from one operating room right across the passageway to the next one. They work better, and it's certainly better before the patient is ever on dialysis. But not everyone is a transplant candidate for a number of reasons. Dialysis, excuse me, is the most common treatment for kidney failure, and this can be done in the kidney center, where typically hemodialysis, which this gentleman on the right has, with a fistula in his upper arm, and blood goes through a filter over here, and then returned with very close monitoring of the blood flow and the pressure and anticoagulation to keep the blood from clotting outside the body. That's typically done 3 days a week for 3.5 to 4.5 hours. Hemodialysis can also be done at home. It's usually done either for a shorter term, like 2.5 hours, 5 days a week, or in larger people or people who have problems with excessive fluid weight gain, or who just want better therapy, and it is absolutely the best therapy, is to do dialysis overnight, 5 to 6 nights a week. In my experience, I've had young people who could return to work, and they say that they felt perfectly normal when that was done. The other big type of home dialysis is peritoneal dialysis, where a catheter is placed in the abdominal cavity, and fluid is placed in there 4 times a day, and the membrane in the abdomen exchanges, allows the waste products from the blood to go into the fluid, and then from which it is then emptied. And then finally, palliative care over the last 10 years has been noted to be an important consideration in what nephrologists call the frail elderly. And these are people who are elderly. They have a number of significant medical problems. And in the studies that have been done, they actually live longer and have fewer visits to the hospital and have a better quality of life when they choose not to go on dialysis. So dialysis really is not for everyone and may not be the best thing for them. In that same group, obviously, transplant would not be a consideration either, because they would not be able to withstand the rigors of that surgical procedure.
Dr. Lombard, question
Dave.
on that care, home care, palliative care is, I know Peace Health is on the cusp of, or in the process of, getting more active in that department of care. I'm not sure what the range of care types that they are going to offer, but do you know, is kidney care part of that agenda that they have?
Dave, if I understand your question, is you mean like what dialysis modalities are available in our community?
Well, if they're doing, if the palliative care that Peace Health is going to offer, if they will offer kidney dialysis or any kind of kidney care in the home environment.
Mhm.
I-
Well, dialysis has been provided in our community since 1980. The Mount Baker Kidney Center and now the DeVita Mount Baker Kidney Center has provided that, and they have a very close relationship with the hospital. So anyone that is in the hospital that requires dialysis gets care immediately as needed. That center does a lot of home training. They do various dialysis type modalities like plasmapheresis. So it's all these therapies are available quite readily in Whatcom County.
I have a question on dialysis.
Yes.
Can you do it forever, or what happens is after a few years it will become ineffective?
It's a really good question, Dan. Of course, nobody can do anything forever, right? That's just not the way things things just don't go that way. But I can tell you that if someone has significant vascular problems or significant heart problems, and I'm just saying that because of the group to whom I'm addressing, the average life expectancy on dialysis is about 5 years. That being said, I took care of one patient who had been on dialysis more than 40 years. He actually was one of the first outpatient dialysis people at Northwest Kidney Center back in the 60s. I've had a number of patients, even patients with type 1 diabetes who have lived 15 years on dialysis. So it spans a spectrum, and usually what happens is it rarely does dialysis end up being the thing that stops it. It's usually additional comorbid conditions that end up being the problem. Unfortunately, the greatest risk to a dialysis patient's life is cardiovascular disease. And we'll talk about that just a bit more in a second.
Thank you.
Okay. Any other questions?
Yes, I have a question. What exactly does the palliative care consist of for kidney patients?
It's a good question, Marilyn. What it does is they continue to receive all the medical care they would when they had chronic kidney disease. So they would continue to see their nephrologist. They would manage their fluid balance, manage potassium, phosphorus. If they have an anemia, they would receive that drug EPO I mentioned before to keep their blood count up. The only thing they wouldn't get is dialysis. If they have symptoms, obviously a big part of palliative care is making sure their symptoms are controlled. So if they start having problems with nausea or vomiting or poor intake as their disease progresses, then we would address each of those individually and provide what alternatives we can for them.
What is the life expectancy generally on palliative care?
Well, that's a good question. It kind of depends what the trajectory of the change in their kidney function is, Marilyn. So if you can imagine over time, the patient starts with a kidney function up here and slowly goes down. Other people go down more rapidly. The people that are going down more rapidly, it's going to be a short time. The people that are more gradual, it's longer. I've had patients live with palliative care for 6 months, whereas I've also had patients of a similar, with a similar collection of medical problems die in 6 weeks on dialysis. And to be honest with you, they usually stop after being hospitalized a number of times. They
Okay,
withdraw
thank you.
care.
Thank you.
Okay. Any others? Okay. So this is just some facts about end-stage renal disease. These are people whose kidneys have failed and are on dialysis or received a transplant. In 2019, 125,000 people in the United States started treatment for end-stage renal disease, and there were 750,000 on dialysis or living with a kidney transplant. Every day, on the average, 340 people start dialysis. 240 patients that are on dialysis die. This is a good telling tale for how well women take care of themselves. Interestingly, women have a higher percentage of having chronic kidney disease through their lives, but for every 2 women that make it to dialysis, 3 men are on dialysis. For the African Americans, this ratio is much, much higher. They're 3 times more likely than whites to develop end-stage renal disease. I'm afraid this really is an indication of the discrepancy in care that is unfortunately still prevalent throughout our country. And likewise for Hispanics, they are 1.5 times more likely to develop end-stage renal disease. Again, this is all assuming a comparable risk profile. And then in the United States, for adults ages 18 and older, diabetes and hypertension, as I mentioned before, account for about 75% of the cases of end-stage renal disease. In terms of the socioeconomic impact of chronic kidney disease and end-stage renal disease, the employment rates when patients are starting dialysis at the initiation is about 23%. And this is for the age cohort of 18 to 55. And that's a decrease from about 38% of those people who were working 6 months before that. And if you look at the same cohort of 18 to 55, 81 to 83% of those are employed. So it's a very significant impact on how these people's lives function. The Medicare eligibility automatically begins at the first of the fourth month after starting dialysis. This is a big deal primarily for financial reasons. This was an entitlement program that started in 1973 when it became very clear that as dialysis was being developed, no one could possibly afford to pay for it. Medicare pays $248 per dialysis treatment, while private insurance or people that don't have insurance and have to pay out of pocket pay about $1,041 per treatment, and their average of 13 treatments per month. So if you do the quick and dirty math for let's just say $1,000 per treatment, these people are accumulating close to $40,000 before Medicare starts paying if they don't have insurance. The Medicare per person cost for a dialysis patient is about $90,000 a year. Again, if you do the math and look at the 248, 13 times 12, it's significantly less than $90,000. And that's because on the average, dialysis patients are hospitalized about 3 times per year. And they oftentimes require procedures to keep that blood access in their arms functioning, and those are also quite expensive. Patients on dialysis make up 1% of the Medicare population, but they account for a rather astounding 7.5% of the costs of Medicare. And in 2017, treating Medicare beneficiaries with chronic kidney disease was over $84 billion, and treating patients on dialysis cost an additional $36 billion for a total cost of something in the neighborhood of about $115 billion. Any questions about end-stage renal disease, chronic kidney disease, the socioeconomic impact? Okay. And this is something I call the dirty little secret of chronic kidney disease. And I'll walk you through this slide so it makes more sense. But chronic kidney disease is a disease multiplier for cardiovascular disease, particularly in patients with diabetes and hypertension. So what this slide shows is kidney failure is said to start with a GFR under 60, okay? So let's say we start at 120 when we're younger, and there's generally a slow decline. So when we're in our 90s, most people have GFRs of 60, all right? And at 60, and the blue line represents, so this is kidney function. The blue line is having no significant protein in urine. The green line is moderate protein excretion in the urine. And then the red line is a lot of protein in the urine. Well, if you look at this 60 and you go up, it's a very mild increase risk ratio, meaning it's about a 1.2 increase. So that means if it's 1, you have the same risk of someone without kidney disease. At 2, you're twice the risk of having that with someone with kidney disease. Well, look what it is for someone up here with a lot of protein in the urine. It's already 4 times cardiovascular risk, mortality risk for patients. And by the time you get to people whose kidney function is now declining into this range, now you're up close to 8% or 8-fold increase, an 800% increase. And the reason for this is that kidney disease aggravates hypertension. It can make diabetes easier or less easy to control. It's associated with lipid abnormalities, which are independent of other problems. A lot of protein in the urine is oftentimes associated with very severe cholesterol elevations and triglyceride elevations. When you have a lot of protein in your urine, the patients usually lose things like antithrombin 3. Name isn't important, but that's one of the things that prevents clots from occurring. So when these people are losing that in their urine, these people that lose a lot of protein in their urine are at an increased risk of clotting. And it can be clots of all sorts, including intraarterial clots. The second thing is so we lose kidney function, calcium and phosphorus become deposited in the blood vessels, creating little calcified areas in the plaques, which again contributes to this increase in mortality that's seen with chronic kidney disease. I know that's a complex slide, and I apologize, but I think it's just an important message that if I had a lot of protein in my urine and even if I had a low normal kidney function, I would want to ask my doctor, what can I do to make this better? Because I don't want to be in this risk category. Any questions?
I have a question. Can a person's let's say somebody has a test and the protein in their urine is elevated, and they take some steps to try to mitigate that. Is it possible that the protein in the urine would go down significantly, or what? I'm talking about people with pre-existing conditions like cardiovascular.
Sure. Yeah. Great question, Mickey. That's a great question. And yes, there are drugs, particularly the statin, I'm sorry, not the statins, but the ACE inhibitors like lisinopril and losartan, which really can significantly impact protein excretion. This is also why we ask that patients that have a lot of protein in urine lower their blood pressure to under 125/75, because when the further you lower the blood pressure, the more you drop from this red line down to this blue line. That makes sense?
Yeah. Okay.
Yeah. So that's a really important thing to keep in mind. Yep.
I have another question. So my husband took some of these drugs, and he never had, at least never showed up in any test. He never had protein in his urine, and he didn't have high triglycerides or high cholesterol or anything like that. So and this may be going down a rabbit hole, but were some of these drugs for heart conditions developed with a dual purpose of helping your kidneys also? I mean, because I'm thinking he got lucky that some of these heart drugs were keeping his kidneys healthy.
A lot of the original research on the angiotensin converting enzyme inhibitors, ACE inhibitors, like lisinopril, of which captopril or Capitan was the first one, were actually designed to lower the pressure and the filtering units in the kidney to decrease protein excretion. So it turns out they were a lot of the initial research was in fact designed to reduce that, and then it found that, well, by controlling this, gosh, people with cardiovascular disease and heart failure do much better than they do when they aren't able to take them. Does that answer your question?
Yes, thank you.
Okay. Any other questions? Okay. For summary, the kidney disease risk and prevalence is much greater than most of us know, and that's one of the things we're trying to get across. Finding out if you are at risk or have signs of kidney disease is actually quite easy. Minuteforyourkidneys.org, or going to the Mount Baker Foundation website is a real quick and easy way to check if you think you might be at risk. And it's very important to find out early and treat early, because then you can prevent or delay the progression of kidney disease. And kidney disease by its nature is progressive. If you have chronic kidney disease, you tend to lose function over time and ultimately end up with kidney failure. But treating it early can definitely delay that. The goals of this initiative, and you might have seen some of the signs already around the town with the hands and the kidneys. Our intent in doing so is by increasing the awareness of the risk and prevalence of kidney disease. We're hoping that patients can become their self-advocates to identify and seek help to control their kidney disease risks, first off. And secondly, by reducing the burden of kidney disease on individuals in the general population by preventing it occurring by controlling the risks, identifying and treating kidney disease early. We can delay the progression and perhaps prevent end-stage renal disease and the people going on to dialysis or requiring transplants. And then finally, remembering that if we have perfectly normal kidneys and someone needs one, we can get by with one. And we really, having a live donor transplant really helps people that are in this situation. Just a message from our sponsor. Just tell you briefly about the Mount Baker Foundation. We consider ourselves a catalyst for community and generational transformation. Our vision is, and this doesn't apply just to this initiative, obviously, but that individuals, families, neighborhoods, and communities become stronger, healthier, and more resilient and more compassionate generation after generation. And our mission is to identify and fund catalytic transformative initiatives that result in sustainable change. The focus areas I mentioned earlier are early childhood care, development and education, upstream factors leading to chronic disease, and addressing the quality of life and quality of care of kidney disease and dialysis patients. And we do this to honor the hopes and contributions of the Mount Baker Kidney Center founders, the physicians, staff, patients, families, and the community that has made all this possible. A look at what we have done over the last 3 years, actually in 2.25 quarters at this point, is just the amount of money we've contributed to various sources. I don't think we need to get into the details of those. So thank you for your time. Please visit mountbakerfoundation.org. There'll be a lot of information about kidney disease and kidney health awareness. And also you'll find out more about the Mount Baker Foundation. And this is my name and email address that if you folks have specific questions that you weren't able to get to today, or you think of tomorrow and say, gosh, I want to ask that guy about this, email me and I will answer. I'll get to it as quickly as I can.
Okay, Dr. Lombard, thank you so very much. Thank you for your presentation, but also on a larger scale, your dedication to kidney health and what you've brought to the community to help us all be better, in our health. Are there any last questions for Dr. Lombard today?
Yeah, I want to ask Dr.
Yes,
Lombard. Does taking a statin make your blood sugar go higher? I read somewhere that it might.
A statin?
Yeah.
No, not generally, Kelly. I don't think so. I mean, there may be something new that I've not heard of, but it's to my knowledge, and we certainly used a lot of those drugs in our patients who did not see it impact their blood sugars. Anyone else? Any questions? Stan?
May I make a comment if it's all right?
Go ahead, Mickey.
I would encourage anybody who's in this meeting and the other people at Mended Hearts, if you are on Facebook, go to Mount Baker Foundation's Facebook page, and you could read more about what this initiative is doing around town. And we're, you know, all of us older people we're kind of like, what's all this social media mean? So anyway, if you can go to Mount Baker Foundation on their Facebook and like the page or follow it or whatever it's called, it would help get this word spread to a broader category of people throughout the county, throughout the world. Thanks.
Thanks, Mickey. Stan, you were raising your hand. There, go ahead. Oh, still can't hear you for some reason, Stan. I'm sorry, Stan, I can't hear you. Brad, can you help him?
Let me see if I can encourage him to unmute.
Yeah, for some reason, Stan, we're not able to hear you yet, so Brad's going to work on that a little bit.
No, Stan's mic is on. He should be able to speak. Go ahead, Stan.
Maybe type it in the chat box, Stan. Unfortunately, we're still not able to hear your voice.
Yeah.
I don't know why. You can email me a question if you have it, Stan. If you use that email address at the end of the presentation, and also we'll make the slides available. I don't know how we do that, David. Do I give the slides to you or to?
Probably to Brad.
Yeah.
Send it to Brad, and he's our.
Okay, great. Okay.
He'll handle it from there.
Yeah.
Okay. Did I send them to you already, Brad?
No, not yet, Doctor.
Okay. Okay. Okay.
Any
Well,
other questions? Okay. Well, I again want to thank everyone for being here today. Thank you again, Dr. Lombard and Mickey, your role in making all of this happen. So thank you so very much, and hope to see you all next month. So.
Okay. Thanks so much, everybody. It was great seeing you again. Bye now.
Thank you. Bye-bye.